Fantastic. I
And
love that.
I'm just starting the recording now so that everyone knows that we are recording it. It's so that people in different time zones can watch the video on it. And Tamara, I'm Linda Burhan-Stiffen, our Linda B. I'm Cherokee Nation of Oklahoma. I've been involved with Native American cancer research since the late 1970s. So worked in universities, UCLA, Cal State Long Beach, worked for the National Cancer Institute, for the Anschutz Cancer Center here in Colorado, and started Native American Cancer Research Corporation in 1998 and started our for-profit Native American Cancer Initiatives in 1999. And we have a new business that we just started in uh, March of 2024 called NavPoint Health that has to do with reimbursement for PIN codes and training and getting people to use a patient navigation record system called Nasi Care that Corey is a member of our research team that developed this tool. So anyway, questions about anything before we get rolling? Okay, Shanna, go ahead and share your screen, and I'm going to put myself on mute so I don't keep coughing.
Okay. Let me get this going. Give me just a second. Oh, hold on. Okay, let me start the presentation. Okay. Well, I just wanted to thank IPIN for allowing me to speak and share our program today. Um, so my name is Shayna Grandbois Herrera. I am Turtle Mountain Chippewa, and my reservation is in Belcourt, North Dakota, which is about 30 miles from the Canadian border. But I was born and raised here in northern New Mexico. I'm also a wife, a mother, and a second generation stone sculptor. I shared some pictures of my life here just so you guys can get to know a little bit more what I'm about. Um, and I am a Native Health Navigator at Christa St. Vincent Cancer Center. We're a nonprofit community hospital, and I've been here for about 12 years, and I've had various roles that have prepared me for the position that I have today. I started as a medical assistant and um, kind of worked my way up as medical assistant supervisor. And before taking this position that I have today, I was the clinic manager for our oncology clinic. Um, and navigation was new to me when this opportunity presented itself. And over time, I've grown into this role through mentorship experience and some formal navigation training through the George Washington University program and the Komen Foundation. And then also with Linda B through the NACI. So New Mexico is home to 23 pueblos, nations, and tribes. 8 of them are surrounding Santa Fe. We also have a large urban Indian population in Santa Fe due to the schools like Institute of American Indian Arts, the Santa Fe Indian School, and we also have a really large art community here in Santa Fe. Many of my patients travel at least 30 minutes to get to their medical appointments. Some come from as far as 3 hours out in Gallup or further in New Mexico. And we started our navigation program in 2023 during a time when disparities became impossible to ignore. And Native patients were delayed in care and lost in referrals and not always heard. So we aimed to build a program that could change that with trust and partnership and persistence. I'm just going to share a little bit of infographics here. So over the last year and a half, we have received 65 referrals, or it's um, our data's a little outdated here, so we've received more than that, but what I'm presenting today is from about 75 patients that we've that have come through our Native Health Navigation program. And a lot of these patients have come from 22 different pueblos across 12,000 square miles of northern New Mexico. And they've ranged from 28 to 93 years old. These patients with cancer not only have to um, consider the weight of their diagnosis, but 37% of them are also reporting insecurities with transportation, food, finances, or housing. And, we suspect that the numbers for those SDOH factors are probably much higher. And we're now consistently capturing that data. This was more so what patients were um, reporting as they were getting intaked as a new patient with the medical assistant. And so our model has three strands that weave together. We have direct navigation, education with associates, and partnerships that extend into the community. So this approach ensures that our patients are supported at every level. And excuse me, we aim to establish a trusting connection with patients. Patients often come to the Cancer Center multiple times a month for an extended period of time. And I often introduce myself as I did in my second slide. Many times that serves as an icebreaker, and we find common ground to build the trust and connection. And, I will follow patients from their initial diagnosis all the way to completion of treatment or beyond. Um, so we really aim to build a good relationship with the patients. And one of the main focuses is to ease the transition of care. I grew up going to IHS, and I was in my mid-20s before I got health insurance for the first time. So I know that it can be extremely intimidating to go to an outside facility where you have to worry about referrals, co-payments, and going to different locations for appointments. Um, Coordinating care to ensure seamless medical support. Because so many of my patients come to Christa St. Vincent with comorbidities, I'm often coordinating with their oncologist and their IHS primary care provider um, to kind of manage those comorbidities with them. And I'm also in contact pretty frequently with the PRC office if patients are needing approval for imaging or consults to another clinic. Um, we also aim to provide education on treatment goals, preferences, and questions, not only for patients, but for attending family members. Oftentimes, I'll write out what the next few months is going to look like for a patient or next few weeks because it's so overwhelming to hear unfamiliar words and then inform them so that they can look back at it when they get home once they have more time to process. And also, I help patients connect them with our resources that we have here at the Cancer Center, like our triage nurses, our nutritionists, social workers, financial assistants, insurance coverage, and Cancer Foundation that we have. We also have some transportation services. And we are definitely really lucky to have so many resources available here at the Cancer Center um, to our patients. And we have, an entire team dedicated to making our patients' cancer journey as seamless as possible. We are, currently updating our data, so some of these numbers are from 2024, but just to give you a snapshot of our impact, among those who were referred as a new Native oncology patient, 46% of them received their first oncology appointment within the 1 week of their referral. One of our biggest goals of the program is as soon as a patient has a positive screening mammogram or colonoscopy, that their IHS primary care provider is picking up their phone and making me aware that we have an incoming patient. And from there, I'm coordinating with our new patient team to get them on the schedule as soon as possible. And behind each of these numbers is a story. Each one represents a patient who made it to care sooner and felt respected and didn't have to face cancer alone. Um, and even though I am the only navigator, I am not alone. We have a biostatistician who helps show impact through data, and my manager ensures that I have support when needed. And then our senior leadership champions the program from the top, and their buy-in has been essential. Um, we are a small but mighty team, and we've really made a lot of progress in the last couple of years that I'm super proud of. And when we refer to our patients, it's really our relatives. We try and approach the care holistically, bringing in family, ceremony, and traditional knowledge alongside medicine. We've really worked to um, educate our oncologists and make them feel a little bit more comfortable asking patients how they're incorporating traditional medicine with their cancer care. And that's been something that we've worked on over the past couple of years that we're really proud of. And we are planning to do some more, hopefully, videos with um, a couple of people from the community to improve um, patient education as well. Um, so relationships come first and data comes second, but both really matter. You know, as a new program, figuring out the different things that seem to be actually important in the long run. It takes time. And, just for an example, it took us over a year to finally get a report out of our EMR to help us identify the Native patients coming in a more efficient way. And I also persisted with collaboration with a nearby IHS clinic, and that's really paid off. We've developed some systems that work really efficiently in getting our patients referred. That also includes monthly check-ins. And over the past few years, I've traveled to several clinics to build connections, like the Taos IHS Clinic, Santo Domingo Tribal Health Clinic, and then the Gallup Indian Medical Center. We've also recently completed our third annual gathering for Native American cancer care. Um, and it's an event that brings together patients, providers, and community members to strengthen collaboration and cultural understanding. We had a great turnout this past year, and last year we were honored to have Linda B as one of our speakers, and we just try and bring new folks in every year to share education with the community um, along cancer um, for to better patients' care. And we're really, our vision is to build capacity, training new navigators, strengthening tribal partnerships, and embedding cultural safety in every layer of care. We recently received a new grant, and we're really excited on some of the initiatives that we're going to work on to improve the program. We're going to work on improving our EMR, which is Epic, and we're looking forward to um, having guidance from an advisory council. And there's, many elements that we are hoping to accomplish here in the next couple years with our Native Health Navigation program. Um, I'd love to hear what's working in your regions and how we can learn from each other. Um, and I would love any questions, comments from anybody. And this is my contact information if anyone wants to reach out. My presentation was a little bit quicker than expected, but I am free to answer questions and definitely will be sharing my slides after the presentation so Linda can send those out.
That's great. You did a great job. Don't worry about it being short. I have several comments and questions. I know Corey does too. Corey always has some as well. But I just want to comment again. I've complimented you before on your stone carving, but to see those pieces is just so powerful. They are just what a beautiful way to introduce yourself to the community. Now, and I have a very we're expanding one of our patient navigation record systems, Care, to include diabetes. And what we find in our survivors, 1/3 of our survivors are diabetic, as well as have cancer. Any idea how many of those 75 survivors from 24 were also diabetic? Any guesses?
Oh gosh, I mean, definitely a fair number of them. I would say for sure over 60% probably have diabetes as one of their
Yeah.
um, but that's actually would be something to track a little bit more specifically.
Well, that's what we're starting to do now. And like Corey brought up last week, how in our navigation tracking system, we don't have data fields yet for foot care for a diabetic. And Corey brought up several things that it's like, yeah, that's what we need to be making certain we're including. And I'm curious, are you involved with the New Mexico Tribal Cancer Plan yet?
No, not directly. I've heard of them and I've seen a couple of the reports that they've put out, but I have not, connected with them directly. I would love
Yeah,
to.
their cancer plan, I think, is one of the best in the country. So when we're together next week in ALNN,
Mm,
make certain I give you the contacts so that you can get involved with them because you're in a perfect position to
mhm,
really be able to kind of tailor what's happening with indigenous cancer care throughout New Mexico. So
mhm.
that'll be a really, really good program to do. And I'm wondering, when you visit with your cancer patients, I mean, they come in and obviously seeing the photo, they're very, very comfortable sitting with you. And I'm wondering, how many visits do you think you have with a patient during the course of their cancer journey? Just a guess.
Um, well, I mean, the treatment patients, I'm trying to check in with them every treatment that they get, so every 2 to 3 weeks. So I mean, I had a recent patient that completed cancer care, and I would say probably 20 20 times throughout the
Great.
maybe year and a half that she was going through all of her different, surgery and treatment and all of that. The only time I wouldn't see her is if I was either with another patient or maybe out of the office, but was still following up pretty consistently.
Oh, yeah. I ask because when we talk with non-native programs, they have a lot fewer interactions. And our
Yeah.
average, when we have tracked things with Nasi Care, has been at least 24 interactions during the cancer journey. And we're looking at like the PIN codes reimbursements, and they look at just like 6 months or a year after somebody gets out of treatment. But we're finding that our patients are needing follow-up care for years and years. And Corey can certainly talk on this, but we have people in our program that still have chronic effects more than 5 years after they completed treatment. And I don't know what it is. I don't know what it is about our culture, our genome, whatever it is that we have longer lasting when we look at other racial groups. So I'm trying to ask more direct questions so that people start thinking about, are you having the same thing that we're seeing? Are we seeing something that's just biased? Or, what else is in there? Um, and then when on transportation, are the CHRs from the Pueblos helping transport the patient much? Do you have partnerships with their program yet?
A little bit. I would definitely like to have a little bit more connection, and I don't know exactly what it is, but I've only encountered them, a couple handfuls of times,
Mm.
either coming with the patient, bringing the patient, and translating, which has been really helpful. Um,
Yeah.
I've also seen quite a bit, especially with our patients that are from the Pueblos, that they would rather handle it themselves or kind of within their family, that they want like a fair amount of discretion because of the way it's shared throughout their community, and they don't want others to know. They don't want any like sympathy or pity, and so I've seen that like, quite a bit with my patients.
Yeah, especially if they're in leadership, if they're in tribal council,
Hmm.
man, talk about getting derailed politically when people find out that you're going through a cancer experience. Yeah, you're
Yeah.
right to be very cautious on that, definitely.
Hmm.
And when you were presenting and you were showing how you're working with the family too, which is so important, because cancer affects the whole family, of course. If there is any way, and Tamara, I'm gonna kind of tweak you, if there's any way to support Shayna coming to New Zealand for the World Indigenous Cancer Conference, this is going to be amazing. But they have a model in New Zealand that is totally based in the family. And it's like, even though we do that in the States, theirs is a stronger foundation than the way we have approached things. I think you would love it. And I think you would learn a lot from it. And right now, there are discounted flights, by the way, since I've been looking up the
Trust me, I
airline.
would love for her to go. It's more
Well,
of
and
a
maybe you should come
This
too,
is why the
Tamara.
international they won't allow us. But
Uh,
if I
well,
could,
and sometimes you can get an external funder, somebody from a foundation who would
yeah,
support for something like this. In New
yeah,
Mexico, you certainly have some great foundations that might
yeah.
actually support it. But in terms of ways to augment what you're doing, I think you would just blossom. Being around some of these, in particular, the New Zealand, the Maori program. The Australian program is beautiful too, so is the Canadian. But the way they tweaked things for the New Zealand one, yes, it's, it's really quite cool. Um,
That sounds
and
amazing.
I do want to talk with you when we're at AONN. It has nothing to do with IPEN, but it's about NASI care and getting reports out, and so that we can do a little bit more. I think you and I talked about it a couple years ago,
Hmm.
but it's in a um, the EHRs aren't collecting the information we need for navigation nor the metrics that we need to justify our program. So, but we'll talk more about that when we're in New Orleans.
Okay. I would, yeah, love to,
Yeah.
definitely.
Yeah, and I can show you an old version. Our old version is on our iPad. But actually during AONN, we will have a demo, and let's make certain you're there to see the demo. Um,
Absolutely.
yeah, because it's quite different from EHRs. We're starting to get more and more complaints, especially with Epic, how difficult it is to get a report out. And we have a couple of Epic programs that have done a great job adding data fields. And I can share with you what some of them have done. I took a couple screenshots with their permission
Mm,
on what they added, and that might give you ideas for what you could do for your program
mhm.
also. Corey, I've monopolized the the conversation here. Corey, I
Oh,
know
that
you always
was
have
fine.
questions.
Um, for one thing, I just Man, your artwork on stone. Oh my God.
Thank you.
In our way, the stone is the grandfather. And so that is the grandfathers. That is incredible. Just incredible. Um,
Thank
One
you.
thing I did want to comment on is I loved how you put you know, I don't know if people realize how diverse the a native population is in New Mexico with all those pueblos
Hmm.
and, the three different languages. I have relatives that are Pueblo from San Ildefonso and Santa Clara. And the three languages and the diverse cultures, and it's just incredible, incredible.
Yeah.
So
Yeah. Mhm.
I was glad you highlighted that because a lot of our populations, urban, natives are being more urban now, and we have a very diverse population. And here in Denver, I don't know if we have maybe 75 tribes that are noted at our 150. You're right.
150 is what we documented. Yeah.
Wow.
Yeah, and so we do work with longstanding tribal organizations, the Denver Indian Center, um, Denver Indian Family Resource Center, you know, just we're lucky there's like 5 different nonprofits that, including us, Nasser, that's been in Denver forever, like at least 25 years. So I was just happy to see you have something similar and how you're dealing with that. And you're right. Privacy is really, really super important. There is still stigma, and I'm really glad that we have a really long-standing survivor group. So, and I've gotten really active lately, going out into powwows and it just kind of normalizing that it's okay to have cancer and and talk about it, publicly. So it's important, very important work that we're doing. Um, my one question is, uh, how many patients do you have, or do you have a lot of patients? Do you see a lot of people using traditional medicine?
It's a little bit harder to know one way or the other. Patients are pretty private about that, and um, some patients will, ask a provider if it's okay if they, you know, take some herbs that, their healer has given them. And, a lot of the times the providers, ask a little bit more details, but it's usually quite all right. And, I don't have a whole lot of numbers on how many patients, and this has been something that I've wanted to learn a little bit more, and I'm working on right now with some connections that I've built over the past couple of years, but how to actually ask a patient, um,
Mhm,
if they're using traditional medicines, and how to approach those conversations with their providers. So I don't have great numbers on that, but um, I feel like um, a good amount of the patients are using some sort of form of traditional medicine.
Yeah,
yeah, we do.
we had big
Yeah.
struggles with this years ago because we had people who wanted to partner with our organization, and they really wanted to get information about details about our ceremonies, and then they would bastardize them,
Mm-hmm.
especially the New Agers. They were absolutely terrible, and the traditional healers were very offended by it. And we had several meetings, and this is back in the late 80s and early 1990s, saying, what if we just ask, how comfortable are you integrating traditional Indian medicine with your Western treatment? And then we wouldn't ask for any details. And that started giving us an opening, and we found that over 90% of our patients were heavily involved with combining traditional Indian medicine with Western. There was also a small group that wouldn't do any Western. They would only do traditional Indian medicine. The issue that we had with that is that for the majority of those who only did that, they did have more advanced cancer later on. And by then, when they added Western medicine, it was so difficult, so hard on their bodies and their spirits and emotions on it. But we found it was really important to reassure people we are not asking any details about ceremony, because it is, and it was more the norm back there that people just wanted to dig in and get that type of information. Tamara, we didn't give you a chance to ask anything yet, and you can ask Corey or I, or you can augment anything that Shayna has brought up, or what would you like to share?
No, it's all been very interesting. I mean, I'm here 2 offices down from Shayna, so I'm involved every day. So, I'm very excited about the work we do. I think what you brought up about the EMR and the data metrics is really interesting. It'll be good for you guys to share because we are starting work with our IT team to build a dashboard to better collect the metrics based on the accrue study. So we are just having the kickoff meeting next week with IT, so we'll start that project. So any information that you guys can talk about next week, it's perfect timing as we really share to see what data we want to collect and what will be best to have in that report because we are building it from scratch now.
Excellent.
Yeah.
So, Shayna, when we are together, we're also going to have Jason from Prisma in North Carolina, and they have added data fields to their program. And let's get permission from him to share because they had it for their nurse navigators. They had a couple fields. They didn't have enough information. Example, you couldn't quantify what they were doing for the outcomes, but that would help you see what they needed. And his program is the social work navigators. And so we tried to make certain that we could get people. Oh, here's Janet from New Mexico joining us too. Great. And here's one of your connections to that tribal New Mexico cancer plan. Hey, Janet, how are you doing?
Good. How are you, Linda? Hi, everybody. Good to see you all.
Good to see you too. We're boasting about your plan again,
Oh, thank you. Oh my goodness. Yeah. No, I'm sorry I'm late, by the way, but I had another meeting prior. But no, I'm happy to share it. We're actually getting ready to revamp it. And I think they plan on getting it sent out by the end of next year, the new version.
Wonderful. Well, Shayna would be a beautiful addition to your program.
You
So she's
need to
doing
join.
yes. And I was going to ask you,
Love to.
there's so many things about your plan that I like. And yours is one of the only plan that really even refers to Indigenous children and adolescents and young adults with cancer. And I'm hoping you're going to be able to expand on that in the next version. It's such a wonderful start, on there, but we do so little for the families that are going through this.
Yeah, no, absolutely. Thank you for bringing that up because that's one of the things that we definitely want to address more on that. And then also something that is becoming very what's the word? It's kind of like the new, I don't know how I want to put it, like the new thing that's up and coming now, of course, is genetic research and making sure that all of our people here in the Southwest are being protected as much as possible. Right now, I'm knee deep in it, and yeah. Anyways, so
Well,
We
I
did
have to chat with you, Linda, about that sometime.
We had a questionnaire that we had included with our curriculum, Genetic Education for Native Americans, that was back in the 1998. And it was actually to help natives make an informed decision. Do you have this? And we could kind of play around with that and see how you need to modify it. It does need to be modified, but we felt that people were some were being pressured into genetic research, and others were really excited about taking part, but they didn't know what should be protected. And we found by using the questionnaire that it helped people go, oh, I need that information before I make a decision. And that was really important. So, Janet, are you going to AONN next week?
No, I didn't know I could sign up for it. So I'll actually be at in Arizona Monday and Tuesday.
Okay.
But when
It's
when is
the officially starts Wednesday through Sunday or
is
Thursday
that
through
New
Sunday.
Mexico?
And it'll be in no, it'll be in New Orleans. It's in New
Oh,
Orleans.
okay, then I couldn't go.
No.
Is there a virtual
Um,
option?
there is a virtual option, and I don't think it's for every session, but go to the website AONN online, and
Okay.
they'll have some of the information and how you can sign up to view the sessions online. There are going to be
That'd be
breakout
great.
sessions, and I don't know which of those will be online yet or not. I'll know by next Tuesday. So send me an
Oh,
email, remind
great.
me. Yeah. Yeah.
Great. Yeah, no, Shayna, we would love to have you as part of our Native American work group. So just I'll put my is there a chat in Microsoft Teams? I'll put my contact information and please just reach out to me. I was once the chair of the group and currently I'm helping our new chair get
Oh, thank you.
organized in that fashion, but we would love to have you. So I'll
Well,
add
thank you. I'd
this.
I'd love to get involved, definitely.
Well, and speaking about genetic, we have a new medical director of research here who just came from UNM, Dr. Brown Glaberman.
Oh,
Um,
Oh,
and
yeah.
she and she's bringing a grant. Well, it's still at UNM, but we're opening up the site here at Christa St. Vincent that involves with genetic screening and educating Native American patients about and how do we talk to the patients about the genetic screening for cancer. The grant is called Juniper. Um, and we're coming on the kind of the tail end of the grant, but they've done an incredible job
in
using artwork and to explain. And she's talking with Shayna a lot to bring it, to our patients here. I'm actually going to be in Arizona next week. I'm wondering, Janet, if you're there for that meeting or not, because it's with
Yeah, for
Mayo and
the
TGen.
yes,
For
that's the one. I'll be there, so I'll see you.
oh,
Yeah.
so it's a small world.
Yes.
Excellent.
Yes.
I'm like, wait a minute, are you gonna?
No, I sit on the tribal advisory committee.
Advisory Council. Okay,
Yes.
I was wondering since you said you were going to be there for a minute. I'm like, I wonder if you're on that. So, oh,
Yeah.
well,
Yeah.
maybe
Oh,
just.
did we lose Linda?
I think we did.
I think we lost her.
So
She'll,
I
I
am
hope she'll
new
come
to
back.
the team. We're new to the team for that grant. So I'm going to learn more about it. Shayna was at the meeting recently, the national meeting for that type of grant,
Okay.
in Denver, to learn more about it. But I'm going to the one in Phoenix, so
Oh, great.
we're
Yeah,
learning more about
wonderful.
it.
You disappeared. You're on mute.
We
We can't
can't
You're
hear
on
hear
you.
mute,
you.
Linda.
You're on mute.
I deserve to be on mute. I hit the wrong button there and I disconnected all of us. I am so sorry. Uh, I wanted to share a screen, and that's where I hit the wrong button. But I wanted to, let's see. This is our website. The IPIN information is a tab on our website. And what I wanted you to know, since you're, Tamara, you're talking about what words to use and so on. Here's the information that Shayna needs to get to New Zealand. Okay, down here anyway. There are resources on here, and the ones that are from the cancer precision medicine plain language, like the terminology. I see the link is broken again. Doggone it! I keep having to repair that link. I don't know what I'm doing wrong on it. Just a second if I can find. Oh darn. Hang on, let me open it up in another place for you. But they went through and they would look at what language we were using with patients as navigators in particular. And this was really interesting because they assessed different people. They looked at professionals. They looked at community members, patients, and so on for what words were important for them to use. And hang on. Ashtemaka. Eche. Eche. Saxon. Consistent terms. This is the infographic. Let me get it over here. That she had used for one of the things, and they were saying these were 33 different terms that we're using. And so these are free. This is their website, Tamara, Common Cancer Testing Terms. And they came up and they felt that it was really most effective to start using words like biomarker testing and genetic testing rather than all the different phrases that we use when we're talking about pharmacogenetics, or anything like this. They've got there's at least 4 infographics and short summary sheets that they have on genetics that might help you out with what you're doing.
Yep.
So but that's the most common website. There's another one that I really like. If I could get my cursor to work here. That's the plain language. I think it was this one too. This is supposed to be on our website. This is the link that I said has been broken. Let me get through they talked about how they phrased all these different words. This is how they came up with their lexicons and what types of words made sense, what didn't. But this whole slide presentation she presented to IIPNN a couple of years ago. And that's the infographic I just showed you. There's one other one that I love that she shared. Let's see if I can find it. Oh, this is, we get so many questions about the biomarkers in like PDA, L1 and whatever. And this is a nice little resource, and they have improved it since she presented it to our group. And that might help you also in what you're looking at when you're looking at subtypes and, so.
That's wonderful. Thank you.
Sure. The other things that are on here, oh gosh, I see a whole bunch of these things are broken. Gee. The Pfizer has come out with new resources. Now, they have the patient navigation book, and they have one that is specific on geriatrics. And it really is nice. Actually, I had just downloaded the geriatrics. I did it accidentally, actually. Let me pull it open so you can see it too. But in the geriatric, it also has a section on some of the genetic terms. And this
That looks
one,
familiar.
the cover is the same as what they came out with in 2017. What's different in the geriatric, it has geriatric in the header. They really need to have a different cover on it. But what I like that they did is they added things such as notes for navigators. And they have these little boxes that are off and on throughout several of these books or several of the pages, like on this one. Here's don't make assumptions about other patients' abilities based on their age, and just little reminders of what's in there. So it's a free download, and it also is supposed to be available on our website. I just have been gone too much to be able to pull it up. When you're playing with what you want to include for, you're going to try to work with electronic health records, take a look at all of the metrics. And we summarize them of what they're asking for, if it's a number or percentage, how frequently they're supposed to be asked. And in your program, you don't try to do all of them. Try to do 2 or 3 and then figure out what works. And then maybe in 6 months, add another one. because it's too much to just jump into it. And I have a better list of this also so that it can actually clarify when you're looking for number and percent, if it's quarterly, if it's every month, and whatever. So it's just an abridged list, again, that's just on the web page. I wanted you to see Corey, and Corey is on this is from one of our trainings. Let's see, Corey, are you under NASI Care? You're under both, I think. And we had to add Corey on separate because she wasn't there there's a picture of Corey. I like the other picture. So she can't show her camera right now, but that's Corey.
Hi, Corey.
And I did want to build on something else that Shayna mentioned in her training. What we find and what we recommend for most people is to do the GW training. ACS has their Lion program. It's only 5 hours. The GW training, and Mandy and her team just revised it. I've been going through it because I'm asking Corey and Lisa, from our program to go through it because it's so nice and comprehensive. It is such a strong foundation. So really, really a good thing to do. And then we add on topics that are cultural. So if they wanted to know, you hit the plus sign. So if you wanted to know specifically how things are tailored in Indian country, but we tailor all the content also because we find there are unique issues. And we have some of the assessment tools that are on there that are required for the metrics and how to implement them better. The acuity tool, Shayna, I know you and I talked about this acuity tool a couple years ago. It probably is going to be released by the end of the year. And so, Janet, what the acuity tool is to actually see what your patient load is. And when cancer centers talk about it, they say, oh, our navigator saw 50 patients in a month. That's not what the acuity tool for. It's to really identify how much intensive time it takes to work with populations such as ours that need more time and effort. And so you may have 2 patients in a week because your patient takes so much time and needs so many referrals to overcome their barriers. And that's what the acuity tool is finally going to be released, we hope, by the end of the year. So that'll be nice. But every time you hear someone talk about it as, oh yeah, we got 60. Well, those aren't high need patients. We are never going to see 60 patients a month in our program. It's just our patients have a lot more barriers and it takes more time to work with the family, the resources, the children, the trauma the children go through when their parents are going through cancer, and so on. Okay, so those are just a few things to let you know where other things are. Wait, I don't want that. I want to stop sharing. There. What else? Tamara, Janet, anyone, anything? What else are you working on? What else do you need help with?
So Tamara and Shayna, are you guys both at Christus?
Yeah.
Yeah. Okay. All right. All right. That's good. No, we've been, like I said, with the Native American Work Group, which is a part of the Department of Health. Well, no, it's weird. So the New Mexico Department of Health sponsors the New Mexico Cancer Council. And so under the umbrella of the New Mexico Cancer Council is the Native American Work Group, who produces the Native American Cancer Plan. So they pay for the person who pulls together all the information for that plan. So what was that?
Can you repeat that? So I can get it straight.
The tier
DOH,
system. Yes.
Then,
So the New Mexico Department of Health sponsors the New Mexico Cancer Council.
Yep.
And then under the New Mexico Cancer Council, the Native American Work Group is a work group or committee that falls underneath that.
Okay.
So so that's how we work. And the New Mexico Cancer Plan, like Linda so nicely pulled up here for everybody. This
I'm-
is the one
I'm
that
pulling yours up too. Don't worry, Janet, I'll get
yes.
it.
No, no, that's good. So in this New Mexico Cancer Plan, there are, I believe, 9 goals that our New Mexico Cancer Council decides are the most the focus areas for the entire state in lessening the burden of cancer amongst cancer patients here. And then we, as a Native American work group, then take a look at those 9 goals and try to figure out through research and everything else, which one of those goals is the most and best to take on in our focus. So if you were to look at the Native American, this one here, so it's implementing the New Mexico Cancer Plan in Native American communities. This, you'll see we selected, if you see in the little overview right there, we selected 1, 2, 3, 4, 5 goals in there. And those are taken from the New Mexico Cancer Plan. So we decided as a group and with our research that we felt that these goals that we selected are the ones that are going to be best, making the most impact in our Southwest communities here in New Mexico.
Look how beautiful
So
this is. You know, I
yeah,
mean,
so it
and
was
they've got,
oh,
yeah,
go,
they've got great objectives. The
yeah.
strategies are important. They've got measures that are so much better than what other plans have done. It's the most beautiful plan.
So if you all are familiar or know Dr. Michelle Sweeney, she was a big, huge part of this and curating this information along with Connie Garcia. So the two of them really did a lot of the research and the groundwork. And if you know anything about Michelle Sweeney, she is a fabulous facilitator and can pull together a group like nobody's business and get ideas and everything in a cohesive and just a manner that really breaks down things. So that's why you notice we have these clear objectives, clear goals, and she did a knockout job on this. And this was also with the help of our Native American work group members who really took things from their perspective and their own communities, and asking other CHRs, CHWs what they saw and what we can add together. So that's my grandmother right there in that circle, by the way. So
Oh, is it really?
yeah. So, but yeah, so that's how this whole thing came together. And it also has an accompanying guide that when I was chair, we put it together. It's called the facilitation guide. So basically, we created slides and a guide that goes along with this so that CHRs or CHWs could take this into their community and present it with just reading the guide. And it has tips and things that how they need to set up the room, how they need to handle conversations. It's really pretty in depth. So we're
This is
looking
just,
forward to creating the new one.
That's
and this is
great.
from the Northern Plains, and Carol Ann Hart. This is what they named their survivorship group after Carol Ann, but she was another one. And they have some really, really nice things in other plans, also. So there's really about 5 key native plans, of which the New Mexico is one of the better ones. We are close to finally getting an abridged version of a Navajo cancer plan updated that will be available
Oh,
by the end
good.
of the year, also. And what we found is that we were looking at the New Mexico plan more than anything.
Oh, that's so nice. Oh my gosh, Michelle would be so happy to hear that. And I'll tell our work group too. They'll
Oh,
be
share
excited to
with
hear
them.
that. They'll be
Yeah.
excited to hear that.
Oh,
That's
yeah.
good.
Good
I'm
work.
glad it's helping. I'm glad it's helping not just our communities, but other communities across the US. So that's good to
Oh,
hear.
yeah. Well, and we, Corey, Lisa, and I present so many places, and we promote your plan. We promote, all the plans in the different areas, but we usually end up bringing out something unique about your plan that the others don't. Example, that your plan looked at Indigenous children with cancer, and then, that you're actually so many kind of just gloss over it. And you have to do things totally different with adolescents and young adults with cancer and children with cancer. The impact on the whole family is so amazing. And you've opened the door to be able to do that in yours. So that's really, really essential.
Well, then I'll make sure they keep that in their focus too, and make it maybe a little bit bigger because we needed to do that. The genetics testing, and then also we wanted to include something in a much bigger scale for veterans as well. So,
Oh, yeah. And there, actually, what I was going to share, it's not allowed to be shared yet. So
okay.
never mind.
We'll wait. We'll wait with
Yeah.
bated breath for the next time.
Yeah, there's other stuff that's going on with veterans and cancer support in Indian country. And again, totally unique issues that you need a different type of a support group for these men and women who have been in battle. And I mean, there's just a lot of different aspects, and none of us have done a good job providing appropriate support and tailoring for what needs to be done.
Yeah.
What else? What else? Anything else that you want to bring up or anything?
Oh, the conference. How's the planning for the World Indigenous Cancer Conference going? Are you
It,
still involved? I'm
oh
assuming.
yeah, just finished reviewing abstracts. The abstracts are really nice. I was sharing Shayna when she was presenting, which when you see the video, you'll see her presentation, but she's talking about how you work with the family. And in particular, the Maori have done such a um, phenomenal work in actually focusing with the family as a foundation for how they treat with the whole cancer experience. And they're going to highlight several sessions on that at the World Indigenous Cancer Conference. Get there, get funding from a foundation to pay for your travel. I just bought 2 tickets today, um, coming from Denver, and it was $1,600 round trip, which for an international conference is not terrible, but get a foundation to pay for it. But come to this gathering. This is in the opening. Oh my God, the opening's going to be phenomenal. It is so based in the strong Maori culture in how we're allowed to work and reinforce and help one another. It is so positive. I just think you will love it. So do find a way to get there.
Wow. Wow. Sounds amazing. Yeah, I really wanted to put in for send in an abstract, and I just couldn't pull my stuff in time together about our cancer plan. So,
They're
but I just
accepting late
couldn't.
ones.
I just couldn't pull it together. I was too busy. So
Yeah, well, you know what, we all are. That is a
next year.
problem. But
Yeah.
it won't be next year. It's every 3 years.
Oh, that's right. It's every 3 years.
So
Okay.
I want to say I just filed this. You wouldn't be eligible to get an award. The awards are for abstracts that you do a little video of what your abstract is, and they will pay for your registration, for the awards dinner, and for one other opportunity. So this is really something good, but they also said they are considering late abstracts. We got a lot of abstracts, but do it. Contact them. Go to the website, and you could say Linda B said I should still try to submit it. Blame it on me. That's all right.
I'll see. I'll see if I can, as my husband says, get my poop in a group and see if I can do it. So
Yeah, and we're trying to see if
I'll
AONN will
try.
actually have a booth at the World Indigenous
Okay.
Cancer Conference. We're revising the book that I never remember the name. What is it called? Team-based oncology care, the pivotal role for oncology navigation. We're just finishing the revisions. It's going through Springer Publishing now, and I just asked if they can bring some of the books to sell at the World Indigenous Cancer Conference also, because we have so much more information in the United States than what they do in Australia, in New Zealand, and even Canada. So this would be a good thing. So there's going to be stuff happening. Phyllis, how are you doing? How are you feeling? Oh, you're muted.
Yeah, there I am. I am, I go back and forth because as I keep going, they have to switch antibiotics on me. And I have been, I was on the flip side, and then they decided to change my medication. And it sent me right back to where I was 4 months ago.
Oh no. Oh
Yeah.
no. Who's
So,
advocating for you? I know you're a good advocate for yourself, but who is Nathan helping you advocate?
not allowed to speak to Nathan.
Oh, okay. You and I'll talk soon. Yeah,
Yeah,
okay.
But
I'm
no,
sorry to hear that. I mean, you were starting to just feel human again. Yeah.
yeah.
Okay. Okay, friend.
But I'm good. I'm gonna be in New Zealand. I I have my money and I just have to do everything. Yeah. And I'm not gonna speak or do anything this time. I'm going to
I'm
listen.
not speaking. It's the first time I haven't spoken. It's
Me,
like, I don't care. I'm trying to get other people to come and get them more involved and to see how much, because we share so many commonalities to help one
yeah.
another. It really is it's a dynamic gathering. What else?
I,
Comments, questions about anything from
well,
anyone? Oh, go ahead,
what I
Phyllis.
wanted to ask you about the conference was, when I first started my program, one of the things I did and continue to do for a very long time was collect all of the literature that was out there that was designed by Native Americans. And so I have one of Judith's, Judith was a great source. And so I have a compendium of all of her books and the things that she gathered. And I think I have one thing left, and I was thinking of taking that and taking it down and letting them know that this is an example, and all they'd have to do is copy it and just get the updated statistics to, replace what's in there, because I've got it from Alaska. I've got them from everywhere.
Why not? Yeah, why not?
I want to gift it to somebody, someone who doesn't have
Yeah.
resources.
I tried to do that. We have two shelves, huge shelves worth of American Indian cancer education pamphlets and booklets that have been developed since 1987.
Wow.
And they were, we was going to make certain that they were in the Native Circle. But when it went to Roswell, which is a wonderful program, but the Roswell Cancer Center only wants to include things that are currently accurate. Well, we have it from a historical perspective. For example, we had Hopi ladies coming to one of our navigation trainings, and they didn't realize that their tribe had actually this beautiful breast cancer education pamphlet that was all designed around a butterfly, and a butterfly is so important for Hopi. And it's like I wanted to keep that together. And so they said, well, we'll pay the FedEx to ship, but if it's not current, they're going to throw it out. And it's like, no, you're not. So it's still sitting in my garage storage area. And it's like, I'm in the same situation you are, Phyllis. I want somebody who's going to have it, that'll be a historical place that other people can see. Because so many young people say, nobody's ever done this on cancer. It's like, yeah, there's about 40 different tribes have done this. Here they are.
Yeah.
Crazy.
That would be interesting. And I'm not sure that the Native, because they have such a huge facility, or they're building one, the Native Bio Consortium. and talking to Crystal Sosi and seeing if there's any kind of interest, and maybe that's something that they could archive for you all. Who
Be
knows?
wonderful. I just would
Yeah.
like it to be accessible to people. Same thing Phyllis wants to do with the literature, that she has. It's just, it would be nice if people could see. There's been a lot of work over the years, but it hasn't been continued. Shayna, you have your hand up.
No worries. I just wanted to mention, Linda, next week at AONN, I'll be presenting a poster for the abstract that me and my coworkers submitted. So make sure you stop by for that.
I will. I
Wow.
will be there. Yeah. Great, great. Anything else about anything?
How comes there's so few people? What happened?
Part of that was my issue. I was gone on travel, and I usually send out more reminders. And also, it's because UICC is going to be down in Australia. People are flying, and so they're not available. So they're saying, "Oh, we want to see the video," which, we get a lot of people who download the videos. So that part's good. But that's why there's so few people. It's nice to give them the early warning to get it on their calendars, but you need other reminders to keep it kind of up and fresh that, yeah, this is coming in 2 weeks, it's coming in a week. And so
That's how AI will do that for you. All you have to do is tell them to do it and pick this listserv, and they'll do it.
well, I don't do AI.
All you got to do is you just smudge your computer. That's all. That's what I do. I smudge.
Smudging is good. Yeah. Anything else? Anything at all? Okay, the next session we're going to have is November, I think it's 18th. It was in the flyer that I sent out. And I'm going to be sharing a little bit about the reimbursement on PIN codes. And I hope by then we have this other resource approved. And if we do, it's going to be a nice way to back into it. But we're really finding people haven't been applying to get reimbursement for using the PIN codes from CMS. There's so much misinformation. Yeah, and that's what we're going to just focus on, making it more understandable and how to talk to your patients, how to talk about that there's a shared expense, that it's the same thing with anything with Medicare.
Yeah, you can say yes and don't worry about it.
Yeah, you never have to collect the money. Okay, anything else? Anything at all? Okay, well, thank you all. Thank you. And Shayna, you did a great job. So do send your
Thank
slides
you.
to me and I'll get them
Okay.
uploaded. And I still am having trouble with the New Zealand one. I still can't get it uploaded. But anyway, and as you saw when I showed the website, I've got a bunch of broken links and I haven't been home to be able to fix them. So I will have
Can't
to
wait
fix
to
them.
see your presentation, Shayna. Sorry I missed it as it happened, but I will definitely download it.
Yes, please, please, please. And I have your email in a new message right now, so I'll send my information over so we can connect.
Okay, good.
You
I'll
will
look for it.
love working with one another. You are both on the same very proactive track. This is going to be a good connection. Yeah,
Awesome.
excellent. Okay, thank you all. All right, have a
Thank
good
Okay.
you.
evening.
All
Thank you
right.
all.
See you
Thank you,
next
everyone.
week.
Hey, Linda,
Bye.
stay
Bye.
on just a
Bye-bye.
minute,
Yeah.
okay?
See you next
Okay,
week.
let me
Bye-bye.
stop the recording though.
Yes.
Stop recording. Yes, okay.